Hey, future RNs! Today we're going to do a full study session on obstructive shock. This is the one that's all about a physical block in the system, not a failing heart. Now, you might not see it as often, but it is super high yield for the NCLEX because it really tests how fast you can connect the dots. You ready? Let's get into it.
Okay, so what exactly is obstructive shock? The easiest way to think about it is this. The heart itself, the pump, is working just fine. The problem is a physical blockage, like a major traffic jam on the highway that stops blood from getting through. So the key takeaway here, and you'll want to remember this, is that it's a plumbing problem, not a pump problem. Just knowing that simple difference will help you distinguish it from cardiogenic shock and answer a ton of NCLEX questions correctly.
All right, now that we know what it is, let's talk about what causes it. And for the NCLEX, there are really 4 big ones you absolutely have to know. These are the ones that show up again and again, so let's lock them in.
So, let's break down these 4 major causes. First up, we have cardiac tamponade. Just picture fluid building up around the heart and literally squeezing it shut. Then there's tension pneumothorax. This is when trapped air in the chest pushes the heart and all the great vessels way out of place. Third is a massive pulmonary embolism. Basically, a huge blood clot gets lodged and blocks the main artery that goes to the lungs. And last but not least, we have superior vena cava syndrome. This happens when that big vein bringing blood back to the heart gets squished, usually by something like a tumor.
Let's take a closer look at cardiac tamponade, because this one's a biggie. You know how the heart sits inside that little sac called the pericardium? Well, in tamponade, that sac starts filling up with fluid. The pressure from that fluid just crushes the heart, so it can't expand and fill up with blood between beats. And think about it, if the heart can't fill, then it has nothing to pump out to the rest of the body.
Okay, now for tension pneumothorax. This one is all about pressure and it creates a really dangerous domino effect. See, air gets into the chest cavity, but it can't get out. At first, that pressure collapses a lung, but it gets worse. The pressure just keeps building and building and it pushes everything, the heart, the trachea, all those big blood vessels, over to the other side. This big shift can literally kink the major veins, like stepping on a garden hose. And that stops blood from even getting back to the heart. It is a true emergency.
All right, so we've got the causes down pat. Now let's shift gears and talk about assessment. What is this patient actually going to look like? This is super important because this is where you'll find all your NCLEX clues. While a lot of shock patients look kind of similar at first, it's those really unique signs that will point you directly to the cause and to the right answer on your exam.
First off, you're going to see those general classic signs of shock that apply to pretty much any type. You know the ones. The body's trying to compensate, so you'll see hypotension, that low blood pressure, tachycardia, a super fast heart rate. Their skin will feel cool and clammy, and their urine output will drop way down because the kidneys just aren't getting enough blood.
Okay, listen up, because this is probably one of the most important things for the NCLEX. We have to lock in the telltale signs for the 2 biggest causes. For cardiac tamponade, the classic pair of symptoms is JVD, that's when you see those bulging neck veins, and muffled heart sounds. It makes sense, right? You're trying to listen through a bag of fluid. Now, for tension pneumothorax, the 2 signs you have to know are tracheal deviation, where the trachea is literally pushed off to one side, and absent breath sounds on the affected side. Let's say that again just to really drill it in. Tamponade means JVD and muffled heart sounds. Tension pneumo means tracheal deviation and absent breath sounds. You've got to know those cold.
So, you've spotted the signs, you know what's happening. What do you do right now? What's your priority? This is where you really make a difference. We talked about it being a plumbing problem, right? Well, your job as the nurse is to help fix that blockage, and it has to happen fast.
Okay, here's the game plan. First things first, no matter what the cause is, you always start with your ABCs. Airway, breathing, circulation. Get them on high-flow oxygen right away. Now for the specific causes. If it's cardiac tamponade, the solution is a pericardiocentesis. That's a big word for using a needle to drain all that fluid from around the heart. Your job is to get everything ready for that procedure. If it's a tension pneumothorax, the immediate life-saving fix is needle decompression. You're basically letting all that trapped air escape, and that's usually followed up with a chest tube. And finally, for a massive PE, we have to deal with the clot. That means giving anticoagulants or even powerful thrombolytics, clot busters, to break it up. So once that life-saving intervention is done, your job changes, but it's just as critical. You're not off the hook yet. Now you shift into monitoring mode. You need to watch your patient like a hawk to make sure that what we did actually worked. Is blood finally getting to those vital organs again? That's the question we need to answer.
So, here's your monitoring checklist. You're going to be checking vital signs constantly. I mean, like every 5 to 15 minutes. We want to see that blood pressure coming up and that heart rate coming down. Next, and this is huge, you need to be watching their urine output.
The goal is more than 0.5 milliliters per kilogram per hour. That number is so important because it's our best indicator that the kidneys are being perfused. You also want to see their mental status improve. They should become more alert as their brain gets more oxygen. And of course, we want that oxygen saturation up above 94%. When you see these things, you know you're winning.
Okay. Whew. That was a lot of information, I know. So let's do a really quick practice drill right now to help make it all stick. I'll ask a question, give you a few seconds to think, and then we'll go through the answer together.
All right, first question. Your patient presents with distended neck vans, muffled heart sounds, and severe hypotension. What cause of obstructive shock are you thinking of? If you said cardiac tamponade, you're exactly right. Those two signs, JVD and muffled heart sounds, are the dead giveaways. Okay, number 2. Your patient has tracheal deviation to the left and absent breath sounds on the right. What is the absolute priority, life-saving intervention? That's going to be needle decompression. You have to get that trapped air out immediately to relieve the pressure from that tension pneumo.
And for our last practice question, this one's a key number for any patient in shock. What is the minimum urine output we're aiming for? You got it. It's more than 0.5 ml per kilogram per hour. Seriously, if you take away one monitoring goal from today, let it be that one. It tells you everything about how well their organs are getting blood.
And there you have it. We just walked through everything you need to know about obstructive shock, the causes, the signs, and exactly what to do. You are so ready to see these questions on the NCLEX. You really, really got this.
Thank you so much for studying with me here at ClearPath NCLEX. If this study session was helpful, go ahead and hit that like button and subscribe. It really helps us make more content for you. And make sure you hit that little bell so you don't miss our next session. Hey, before you click away, drop a comment below and let me know which one of these causes is the trickiest for you to remember. I promise I read every single one. Keep going, you're doing amazing, and you are so close to that RN.